Welcome to this session. My name is Haytham Mekawi, consultant of anesthesia and intensive care. This slide introduces the fundamental physiological principles governing the human brain's function, structure, and internal pressure dynamics. The brain is enclosed within a rigid skull, and its physiology is influenced by the interaction between brain tissue, cerebrospinal fluid, and blood. Understanding how these components coexist within a fixed volume is essential in anesthesia and intensive care medicine, especially when managing patients with head injuries or increased intracranial pressure. This presentation will explore brain anatomy, cerebral blood flow, pressure-volume relationships, and the clinical principles behind intracranial pressure management. By the end of this session, learners will be able to understand the structural characteristics of the human brain, including its weight, cellular composition, and number of neurons. Explain the Monro-Kellie doctrine, which describes the compensatory balance within the closed cranial vault. Describe the physiological mechanisms and control of cerebral blood flow, which is critical for maintaining adequate oxygen and glucose supply to brain tissue. Recognize the clinical relevance of intracranial pressure and cerebral blood flow regulation in intensive care and anesthesia practice, particularly in conditions such as traumatic brain injury or neurosurgical patients. The adult human brain weighs approximately 1,300 to 1,400 grams in males and 1,200 to 1,300 grams in females, and has a volume of about 1,200 to 1,500 milliliters. It contains roughly 86 billion neurons, with about 69 billion located in the cerebellum and around 16 billion in the cerebral cortex. These neurons are supported by approximately 85 to 100 billion glial cells, which provide structural and metabolic support. Although the brain constitutes only 2% of the body's mass, it consumes about 20 to 25% of the body's resting oxygen and glucose supply. This high metabolic demand underlines the importance of uninterrupted cerebral blood flow. The Monro-Kellie doctrine states that the cranial cavity is a closed compartment. It contains brain tissue, cerebrospinal fluid, and blood. Since the total volume within the skull cannot change after fontanelles close in infancy, any increase in the volume of one of these components, such as brain swelling or increased blood volume, must be balanced by a corresponding decrease in another component, or intracranial pressure will rise. Failure to maintain this balance may lead to dangerous consequences such as brain herniation and reduced cerebral perfusion. Intracranial compliance curve. This curve illustrates how intracranial pressure changes in response to increasing intracranial volume. Phase 1, compensation. Initially, small increases in volume are accommodated by shifting cerebrospinal fluid to the spinal canal and displacing venous blood. Phase 2, limited compensation. As volume continues to increase, the compensatory mechanisms begin to fail and intracranial pressure starts to rise. Phase 3, decompensation. Beyond a critical threshold around 20 to 25 millimeters of mercury, intracranial pressure rises sharply, leading to potential cerebral herniation. Normal intracranial pressure is between 7 and 15 millimeters of mercury. Prompt recognition and treatment are required. When it exceeds 20 millimeters of mercury, cerebral blood flow is the amount of blood delivered to the brain per minute. In adults, it ranges between 750 to 900 milliliters per minute, accounting for approximately 15% of the total cardiac output. Gray matter, which is more metabolically active, receives about 80 milliliters per 100 grams of tissue per minute, while white matter receives about 20 milliliters per 100 grams per minute. Adequate cerebral blood flow is vital to ensure a constant supply of oxygen and glucose, which the brain depends on to function properly. Cerebral perfusion pressure is defined as the difference between the mean arterial pressure and the intracranial pressure. Cerebral perfusion pressure equals sign mean arterial pressure. Intracranial pressure. This equation reflects the pressure gradient that drives blood flow to the brain. Normal cerebral perfusion pressure ranges between 60 and 80 millimeters of mercury. If intracranial pressure increases or if arterial pressure decreases, cerebral perfusion pressure falls, which can lead to cerebral ischemia. The brain can autoregulate blood flow when mean arterial pressure is between 60 and 150 millimeters of mercury. Mechanisms of cerebral blood flow control. Cerebral blood flow is tightly regulated through several mechanisms. Autoregulation The cerebral arteries constrict or dilate in response to changes in mean arterial pressure, maintaining stable blood flow between 60 and 150 millimeters of mercury. Chemical regulation increases in carbon dioxide or hydrogen ion concentration. Low pH cause cerebral vasodilation, increasing blood flow. Severe hypoxia oxygen tension, less than 50 millimeters of mercury, also leads to vasodilation. Metabolic coupling, blood flow increases to areas of the brain that are more active, delivering more oxygen and glucose as needed. Neurogenic control autonomic nervous system input, particularly from the sympathetic and parasympathetic branches, can influence large cerebral vessels. Chemical regulation of cerebral blood flow. Several chemical factors influence cerebral blood flow. Increased carbon dioxide causes vasodilation, increasing cerebral blood flow. Decreased carbon dioxide leads to vasoconstriction and reduced blood flow. Severe hypoxemia oxygen partial pressure below 50 millimeters of mercury triggers vasodilation. Acidosis low pH enhances cerebral blood flow, while alkalosis high pH reduces it. Carbon dioxide is considered the most powerful regulator of cerebral blood flow under normal conditions. These chemical changes are especially important in the management of ventilation and acid-base status in critically ill patients. How to lower intracranial pressure? Management of raised intracranial pressure is a critical task in anesthesia and critical care. The following strategies are commonly used. Elevating the head of the bed to 30 degrees improves venous drainage and reduces intracranial pressure. Maintaining adequate cerebral perfusion pressure through appropriate mean arterial pressure support ensures sufficient brain perfusion. Controlled hyperventilation lowers carbon dioxide levels, causing vasoconstriction and reducing cerebral blood volume. However, excessive ventilation can lead to ischemia. Osmotic agents, such as mannitol or hypertonic saline, reduce intracranial pressure by drawing fluid out of the brain tissue. Sedation and analgesia help prevent coughing, agitation, or straining, which can elevate intracranial pressure. Avoiding hypoxia and hypercapnia is essential to prevent secondary brain injury. Preventing hypertension is equally important to avoid compromising cerebral perfusion.